Tonight, we're very fortunate to have an excellent and interesting specialist physician, Savas Petrides, who has been here in the Valley, now I'm trying to remember if it's 15 or 18 years.
18.
18 years, thank you, practicing as a nephrologist. Dr. Petrides is joining us tonight to talk about his special area of interest and knowledge, which is nephrology or kidney function. Savas, please join us. A little round of applause, please. Savas, thanks very much. Have a seat. Thank you. Get yourself comfortable. And thanks for being here tonight.
I never knew anybody actually wanted to know what I thought.
Well, we're going to be the first then. So, I want to start, Savas, by talking a little bit about yourself. And I've known you a number of years, but we work together, so I know you in a very professional fashion.
Yeah.
So I want to hear a little bit about your personal story so we can all know a little more about you. We'd appreciate that.
Okay.
Don't get too personal now.
I wasn't born in a house my father built. I grew up in New York City. That's why I have a little bit of an attitude sometimes and sarcastic way about myself.
Okay.
I'm Greek by heritage and came from a ethnic family of immigrants who came from Egypt and Cyprus. My grandfather left Cyprus when he was 8 by himself and went to Egypt to work, where he eventually had my grandmother came over, and it's a long story from there.
We don't have that long.
One of my uncles was actually born on a ship in the middle of the Atlantic Ocean, so we're not actually sure what his nationality was. Born and raised in New York City. I went to undergraduate school at Boston University, and from there I went down to Philadelphia and I did my medical school training at Hahnemann University.
Where?
Hahnemann University in Philadelphia, which doesn't exist anymore. It's now Drexel.
Oh, really?
They took over the medical school from the Hahnemann Medical School, so it's now the Drexel School of Medicine.
Yeah.
And I was there as a student, as a resident. I was a chief resident and an instructor in medicine there. Before I did my fellowship, I went to the University of Pennsylvania for my nephrology fellowship, and I did some research in autoimmune diseases and transplant training at the University of Pennsylvania.
Now, the University of Pennsylvania, that's like the place for nephrology, isn't it? I mean, like history? Is it like the history of nephrology? No, seriously.
There is a long,
the Wistar
there's
Institute?
a long history of nephrology at the University of Pennsylvania, and some of the founding fathers of renal physiology, hypertension, and electrolyte disease were at the Wistar Institute in the University of Pennsylvania before the days of dialysis and transplant and all those things. So the forefathers of what we do in nephrology, a lot of them started at the University of Pennsylvania.
Very good. And so I want to know why you became a nephrologist of all things. I mean, obviously it's not the glory of cardiology, cardiovascular surgery.
Well, it's funny because I was going to be a cardiologist.
Oh, hello.
I was going to be a cardiologist. I did cardiovascular research as a student. I did cardiovascular research as an intern at Children's Hospital in Philadelphia. And then I did my nephrology rotation as a medical student, and I did it again as a resident with the same nephrologist at Hahnemann. It's a personality thing. You click with a certain group of physicians, and that's who you want to emulate, that's who you want to work with. Cardiologists are just not a whole lot of fun. I mean, if any of you see cardiologists, it's like, you can crack a smile every now and then. And
so nephrologists are more jovial?
Nephrologists tend not to take themselves that seriously.
Really? Okay, very good.
I know I come across as a serious person.
You guys are very knowledgeable and serious, but okay. All right.
But nephrologists are a little bit more realistic about who they are and how they interact with people. And I think it's a very non-technical specialty. There isn't a whole lot of sophisticated tests and fancy machines we use, dialysis being a separate thing. But in terms of diagnosis and management, it's really what's up here. And it's knowing some basic science and having some good clinical experience to make decisions that are not based on reading a scan or doing a catheterization. It's just not that clear cut. So it's intellectually very stimulating. And nephrologists are interesting people. I was a resident, and we had about 35 patients on our service to see, and we're doing rounds. And I worked with this nephrologist, Larry Krevlin. And Larry was gold bracelet, long hair, wore $1,000 silk shirts and ran around the hospital like a nut. And we're on rounds, and it's really busy. It's like 4 o'clock in the afternoon. We have another 20 people to see. And he gets a phone call from the mother of one of his patients. And we stopped for 45 minutes for him to talk to that mother and discuss her son's problems. And whatever else was going on was irrelevant. She needed to speak to him, and that was the only thing that was important to him. And that struck a chord with me as a specialty that just fit my personality. And you'd never think he would do it looking at him, that he was that type of guy, but he was that type of guy. And,
so
that's what I've done ever
you.
since.
Personalities,
personality,
the topic.
It's the science of it, and it's pretty interesting what we do.
Now, I must say that I think kidneys are somewhat of an enigma to patients. Now, I don't want to say an enigma in the sense everybody knows what the kidneys do. They sit back here, they cause pain, kidney stones, whatever. And and I think the way we all know about our kidneys obviously is our urine flow, which of course for a nephrologist or an internist, you guys, a patient may say something about the urine flow, and patient, doctor's like, that doesn't really matter about the kidney. Yeah. We're dealing with very different issues. But from a patient standpoint, what are sort of the big things that you think are sort of maybe the myths about the kidney or interesting facts about the kidney, or things that just, that are unknown or erroneous erroneous things about the kidney?
The function of the kidney is more complex than we think, and that most lay people understand. And those of you who see me in the office, I make it pretty simplistic. It's just a dump filter. That's my line. It's a dump filter. And all it knows is the blood that's pumped to it. And that's the function of the kidney that we all see and understand, and that's how you make urine. So your kidney is a dump filter, and it runs off the blood that is pumped to it from your heart and regulates your fluid balance and gets rid of poisons. But there are multiple other things that your kidneys do. They're integrally involved in your blood counts. The production of red blood cells in your body is regulated by a hormone that's produced in your kidney. The regulation of calcium, phosphorus, and the strength of your bones is regulated by activated vitamin D, which is produced in your kidney. It's integrally involved with parathyroid hormone, which comes from 4 little glands in your neck, sit underneath your thyroid, and they regulate your bone strength. Well, that's controlled by your calcium and your phosphorus and your vitamin D that is controlled by your kidney. One that a lot of people don't know until they wind up on dialysis or getting transplanted is that your kidney's involved in diabetic management. Insulin is metabolized by insulinase, which is produced in your kidney. So if you're a diabetic, you wind up with kidney disease and you go on dialysis, most of the time you don't need any diabetic medicine anymore, because the insulin you produce, and this is typical of type 2s, now lasts a much longer time, and so the insulin requirement or the oral medication requirement goes away. We then transplant those people and their diabetes is right back because now they have a healthy kidney and they have their insulin clearances back to normal. So there is these other dynamics of what your kidneys do for you that are above and beyond just fluid removal and cleaning. And we do dialysis on a lot of people. And it's the goal of every nephrologist is to get every patient with chronic kidney disease or renal failure transplanted. That's our goal. The reality is we can't do that for everybody because of other issues with individuals that they can't get transplanted. Dialysis replaces about 15% kidney function. And the function we're talking about is water removal, poison removal, electrolyte balance. Doesn't do the anemia, doesn't do the bones, doesn't do these other hormonal and metabolic processes that you need your kidneys to do. We manipulate that with medications, injectable hormones and things like that. But when you give a new kidney to somebody, you get all that and you get 60% kidney function, not 15. So the sense of well-being, of quality of life, length of life is better transplanted. This is something Doug and I were talking about on the side about transplant. I harp on transplant a lot because I'm a transplant nephrologist. That's most of what I do is renal transplant medicine.
And can we talk about that a bit, Savas? Look, I think we're jumping into an area that I think is of interest. I think a lot of this, everybody in the room, if they're, I don't know if anybody here is on dialysis. I don't see anybody that I know who is. But if they're not, they're sitting there thinking, God, that's one that wasn't on my list to worry about. Now dialysis, I got to think about that from now on. So let's just jump right into the bad stuff, which is, and I say the bad stuff, I mean, the rest of us are sitting out here with good kidneys, we hope, and we got to talk about how we know this, but okay, so we all hope we have good kidneys, but now we're talking about dialysis, which some of us sounds like maybe the end of the world, but it is not, obviously. Thank God for dialysis, a great technology which allows us to maintain people that, and this, when was dialysis sort of become a sort of a more routine offering, if you will, among medical practice, roughly? 70s?
I'm not that old.
70s?
But it was really in the 70s. In the early 70s was when a couple of things happened. One, the technology got better. So they went from these, let's take a step back. So dialysis is very simple. Your blood, this is hemodialysis, the basic, most common dialysis. Your blood goes through a filter, and as it passes through the filter, blood's going this way, a solution of electrolytes and purified water runs against that blood, separated by a thin membrane. And poison and water is pulled out of the blood and into this fluid, which then goes down the drain. In the old days, that blood was pumping through these coils in these big open vats of salt water. Not very clean, not very sophisticated. In the late 60s, early 70s was the development of what's called a hollow fiber dialyzer, which is a plastic cylinder with all these little tubes through it, which is what the blood flows through. And through that chamber, around those little tubes, is the dialysis fluid. So that technology came into play. And the second thing was Medicare. You know, in the early 70s, Medicare decided to pay for dialysis for anybody who needed dialysis. And that remains in place as a right of every Medicare eligible person in the United States to have dialysis paid for by Medicare. Prior to that, you really did have death panels. I mean, there was limited supply of dialysis, there was limited resources, and there were panels in hospitals, and I knew physicians who trained me participated in those panels because they were of that generation. And it was really simple. If you were young and had a family and were their provider, you got dialysis. If you had no dependents who were dependent on you, or you had other medical problems, you did not get dialysis, and you were managed conservatively until you died of renal failure. So in I think it was 1972, Medicare decided to cover everybody.
Yeah. And this is a big, I mean, for the history of it, not to go into boring things, but I mean, it was a big political decision, and it ended up being an extremely costly decision because
very, very costly.
This is a multi-billion dollar program now, which of course at the time people were like, well, this won't be that expensive, and it's enormously so. Not to take away from it or say that it wouldn't be worth doing, but it's just an enormously expensive thing that we all agree to.
Yeah, and I mean, the reality is there are, I don't know now the number, probably
how many
400 to 500,000 people on dialysis in the United States.
That's amazing.
Out of tens of millions of Medicare beneficiaries.
Wow.
But they use 18 to 20% of the Medicare dollars. So, you know, there's this discrepancy. Now, you're talking about a fatal disease that is being treated, and people have very productive, successful lives on dialysis for many years. So, whether it's worthwhile or not, I mean, it's a difficult decision.
It's a decision everybody's made. It's been made for us, so to speak. And I don't want to go there, but I do want to talk a little bit about what, you know, about kidney function, levels of kidney function. Let's talk a little bit about that. I want to come back to transplant. But levels of kidney function. So let's say I'm an 18-year-old kid, and I'm like, okay, I've got 100% kidney function. True? 18-year-old kid? Healthy?
Yeah, assuming no.
Yeah, assuming you're healthy. Okay,
problems.
now let's say I'm a 60-year-old guy. What percentage of kidney function do I have, generally speaking?
So around 80%.
Okay, 80%. Okay, so I've lost 20%. I don't even know it. I'm 60. I still think I'm 100%. Okay, okay, I mean,
that's an appropriate renal function for a 60-year-old.
And this is because of wear and tear on the kidney?
Just natural aging of the kidney.
Okay.
If you biopsy a 60-year-old kidney, you're not going to see all the filters of the kidney looking normal. I mean, you're going to see some old, scarred, non-functioning little filters but that's the natural aging of the kidney. And it does not portend any further problem beyond that some GFR is lost naturally with age.
And you're talking about something called GFR, which is something, are you guys familiar with GFR? Have you guys seen this on your blood work?
Yeah.
This is a new blood test or a new calculation.
Yeah, we need to talk about that.
Yeah,
That's
we
a big deal.
do we want to talk about this?
Yeah,
okay, well, let's talk about BUN. Now, the normal way we usually think about measuring kidney function is in the blood work. That's how we know how our kidneys are functioning, and we do it by a blood test, and it's one of the standard panels of blood work that we do, the kidney function test, and we call it the BUN and creatinine, or people call it the BUN and creatinine for fun. But that has essentially is being supplanted by these three letters called GFR, glomerular filtration rate. And so you can tell us sort of the difference, why we're doing this,
Sure.
and what kind of problems it's causing among everybody.
So we'll start with BUN, and just to get it out of the way. So BUN is a toxin that comes from what you eat. It comes from the metabolism of protein. If you sit down and you go to Don and Charlie's and have a 16-ounce steak, the next day your BUN is going to be higher because you're going to burn up all and metabolize and digest all that protein, and you're going to create BUN. So BUN is not a good measure of kidney function.
Because it varies.
Because it
based on your
varies.
meal. Okay.
If you get dehydrated, your BUN goes up, creatinine won't change. So it's not useful for that reason. We use it for other things in our patients, more on the dialysis side, or in the ICU when we deal with some sick people and protein metabolism, things like that. But it's not good for measuring kidney function. So when you're looking at your kidney numbers, don't worry about the BUN.
Okay.
Creatinine is a good indicator of kidney function.
And this is the CR on the lab, CR.
If you understand a few things about creatinine. So creatinine is a good measure of kidney function because in chemistry, it's what is called a very well-conserved molecule. What that means is it's only produced in one place, and it's produced from your muscle. Nothing outside really affects your creatinine. Your muscles burn creatine, right? The muscle guys, they drink creatine, they want to get big and strong. We don't do that because we know it's not good for you. Creatine is burned with your daily muscle activity. The waste product is creatinine, which is just a metabolized form of creatine. So it's only made within your body. You only get rid of it one place, and that's through your kidneys. So the level of creatinine in your blood is proportional to your kidney function. True kidney function is how much blood is cleaned every minute through your kidneys. That's kidney function.
So that's how the scientist measures.
That's how they measure it. So what you want to know is how much blood is cleaned every minute by your kidneys. That's your GFR. Glomerular filtration rate, the rate of blood cleaned through your glomeruli, which are the little filters in the kidney, every minute.
Okay.
So it's very linear, the relationship, which means if I double your creatinine, I've cut your GFR in half. If I double it again, it's in half. So if you start with a creatinine of 1 and a GFR of 100, and your creatinine goes to 2, your GFR is now 50. If your creatinine goes to 4, your GFR is now 25.
Now, when do you have, this is important because, I mean, I think talking about a very important concept, just that creatinine to GFR, and this number GFR has now become more, we're now, if you will, the lab is now calculating it, if you will,
Correct.
and placing it in the lab work that you guys get so that you can see what's my GFR. So this is part of the new transparency of medicine. I mean, the secrets that we used to keep from you guys are disappearing. We don't get to keep secrets anymore.
We have a few secrets.
Well, maybe a few. But GFR, we won't tell you about those. Keep coming back. No, so the GFR is a measure of that. Now, when would a person be, now what level, like you talked about dialysis gives you a GFR of what? Is equivalent to a GFR of 15?
So let's talk about the lab first.
Yeah,
and then we'll talk about the
Okay.
levels,
Sure.
or the stages of chronic kidney disease.
Okay.
So understand, the GFR measurement, it's not a measurement, the GFR calculation on your labs is not accurate. It's placed there as a screening tool so we don't miss anybody with chronic kidney disease. There are varied ways of measuring GFR, from calculations to actual physical measurements. So remember what I said, your creatinine comes from your muscle. So your muscle mass has a big impact in what your GFR is for any given creatinine. What the lab does is they calculate your GFR based on your creatinine, but it does not take into account your age or your muscle mass, your lean body weight. So the younger you are and the more muscular you are, the more it underestimates kidney function. So it's not unusual every few months that I will get a consult in the office for someone with a GFR of 50. And they're
So 50% of normal
50%.
function.
The GFR in the lab says creatinine's 1.2, GFR is calculated at 50. I look at them, 6'1", 250. A little chubby, not too bad. And I say to him, I said, your GFR is normal, but come on in, we'll talk about it. Because it doesn't take into account the muscle mass. If you're 80 years old and weigh 110 pounds, it's probably accurate. Short of that, it's going to be to some degree underestimating kidney function. But that's the goal of a screening test. We don't want to miss anybody. It's better that I see a couple of people a year with normal kidney function who I reassure and send home than miss the other 90 patients who have kidney disease, who I need to see to help prevent progression of their kidney disease. So what we do in the office is I recalculate the GFR with a different formula that takes into account age and body weight, and I calculate a different GFR for every new consultation I see. And just about everybody we see will at some point get a 24-hour urine collection, which will actually measure creatinine excretion and give us a calculated GFR. If you've ever done a 24-hour urine, you won't see GFR. It'll say creatinine clearance. It's the same thing. Different names for the same thing. So why is it important? Well, it's important because the level of your kidney function determines what we call the stage of your chronic kidney disease, and each stage has different complications and requires different types of therapy and interventions. So there are 6 stages of chronic kidney disease. Stage 1 is normal GFR, which is a GFR over 85, and you're at risk for kidney disease or have some risk factor, hematuria, blood in the urine, protein in the urine, a family history and hypertension, or some risk factors for chronic kidney disease and loss of GFR, but it's still normal. Stage 2 is a GFR from 85 down to 60. And a lot of folks in that, a lot of you were probably technically stage 2
typical,
because your GFRs are low just from natural aging, but you don't have kidney disease. So oftentimes we'll follow stage 2s once a year just to make sure you don't progress, especially if there are risk factors. If you have stage 2 and you have cardiovascular disease and diabetes and hypertension, and certainly if they have protein in the urine, that's someone we would follow. Stage 3 is the largest stage. That's from GFR of 60 down to 30. And stage 3 is a real mix of different subgroups. And this is something that we're learning over the last several years, that you can separate 3s into 2 groups. 3As, which is 60 to 45, and then 3Bs from 45 to 30. The 3As you could just follow on an irregular basis, maybe every 6 months. And as long as they don't show signs of progression, you just keep an eye on them, good blood pressure control, good diet, and exercise. 3Bs are at much higher risk of progressing to stage 4, 5, and onward. And the other risk factor in stage 3 is if you have protein in your urine. Protein in the urine with chronic kidney disease is an independent risk factor for worsening kidney disease.
Now, there should be no protein in the urine.
There should be no protein in the urine. Okay. If you have decreased kidney function and no protein in the urine, the odds of progressing to end-stage kidney disease in your lifetime is quite low. If you have chronic kidney disease stage 3 with protein in the urine, you will progress to end-stage renal disease at some time over your lifetime, most likely, unless we can modify your risk. And there are things we do to modify risk and slow progression that something else gets you before your kidneys get you. Stage 4 is from 30 to 15 GFR. And this is the group that requires the biggest attention by a nephrologist. Stage 4s we see every 2 months. This is our practice standard. Sometimes we don't because of we're busy, you're busy. But our goal is to see a stage 4 every 2 months At stage 4, we do the education and preparation for dialysis. At stage 4, we do the education and preparation for renal transplant. Most stage 4s need treatment of anemia, treatment of bone disease.
Now hold on, you just got me scared when you said, I mean, if I'm a patient and you're very early on here, I'm at stage 4 and you're saying transplant. I mean, that's a scary proposition just to even get your head around.
Well, it is very big issues, very all-encompassing issues, but this is why we do it so early. You don't have to be on dialysis to be transplanted. Our group transplants hundreds of people a year. We're one of the most successful nephrology groups for transplanting people in this country. More than half our patients are transplanted preemptively before they're ever on dialysis. UNOS is the organization that regulates or organ transplantation in the country. The rule is when your GFR is 20, you could be listed for a kidney transplant. Most people with chronic kidney disease don't need dialysis till their GFR is less than 10. In our group, our non-diabetics start at a shockingly low GFR of 7, is the average GFR when we start someone on dialysis. You know, there's a lot of time between 20 and 7. There's sometimes years between 20 and 7. And if you don't have a living donor and you're going to sit on a transplant waiting list, you want to be on there when you're 20.
Now, how long does it take, speaking of transplant, just curiosity, how long are people generally on such a transplant list? And this is for a non-related donor we're talking about, correct?
For a non-related donor, wait time depends on blood type. O is the most common blood type, so it's the biggest list and it's the longest wait time, and that's 3 to 5 years. ABs and As are a little shorter, maybe 2 to 4 years. Bs are about 3.5. It's a pretty small list, the Bs and the ABs. But the sooner you get on the list, time's ticking. There are changes that are happening this year from UNOS in terms of allocation of kidneys, and they're going to a system to match the longevity of the recipient to the longevity of a kidney. So very simply, you don't want to give an 18-year-old kid a 60-year-old donor's kidney, because that's a kidney that may only last 15, 20 years. And if you're 18, you don't want to go through too many transplants. Each successive transplant becomes a little more difficult in preventing rejection.
And what's the longest a transplant has lasted to date? I mean, I met a guy with a liver transplant who walked in my office from Germany, 25 years with a liver.
Livers are easy.
Livers are, seriously?
Yeah, livers are
kidneys
easy.
much...
Kidneys are more
likely to
immune
rejection?
stimulating, so you
Okay.
have more risk of rejection. Livers really, once you get out a little ways, don't need much immunosuppression. The biggest problem with livers is recurrent disease. A lot of the transplant is done for hepatitis C, which is a chronic recurring disease. So it does recur in organ transplant. But there's actually some new hep C medicines. But we're digressing to liver disease. So how long?
Yeah, how long, what's the longest you've seen a kidney transplant?
40 years.
Okay,
I
so
mean, I have patients
extraordinary.
that I see in the office who I'm the third nephrologist in our group that has followed them. The other guys have retired. They just keep handing them off to the next guy.
Now, does that amaze you? Is that like shocking given what you
doesn't.
remember from the old
No,
days?
it doesn't. We know that the immune system has the ability to develop what's called tolerance, to recognize foreign tissue as yourself. That's how we are as babies. Our immune system develops as infants. And the process by which our immune system develops is such that we recognize all the pieces of our body as ourselves. So you don't reject your own kidneys because they're yours. There is a subset of transplant patients who develop tolerance towards their organs. And if you look at these people who are 40 years out, they're on very little immunosuppression. I mean, they were transplanted before we had the drugs we have now. And they have normal renal function 40 years out. So it doesn't surprise me.
So the transplant can be a very long, fruitful,
Very much
extended,
so. Very much so.
longer than your doctor lives life.
The best data we can use is what's called a half-life. So, that's what they use in the transplant world now. So, how long is it for that half the kidneys are still working? And right now, it's about 10 to 12 years. So, if you're transplanted today, there's a 50% chance that you'll still have a functioning kidney at 10 to 12 years. But there's a bit of a selection bias. So kidneys that are going to have trouble tend to get lost fairly early. Kidneys that are going to do well tend to do well a long time. it's just the nature of the beast. It's a very imperfect science, transplant medicine.
Well, I want to come back to this if we have some time at the end. I want to get to some topics that I think are going to be of general interest. I mean, these are of interest, obviously, but I think these are things where hopefully people are like, well, not me, but let's talk about some things that, how do we stop ourselves from needing a transplant? Let's talk about how we keep our kidneys healthy. So what are the things that we're all doing right now that are bad for our kidneys that we don't even know? What do you think they are, if anything? I mean, we're taking too much Tylenol or Advil? Let's talk about that.
So,
is that a problem? Tylenol's been big in the news.
Well, Tylenol
Too much Tylenol
is more liver toxic. But when you've taken enough Tylenol to cause liver dysfunction, you're going to now develop some kidney dysfunction. But it's a pretty big therapeutic window from taking Tylenol to having kidney problems from Tylenol. You got to take a lot of Tylenol. Non-steroidal anti-inflammatories, ibuprofen, Aleve, all these things are a whole different ball of wax.
Okay.
So there is actually a variety of kidney disorders that come from taking anti-inflammatories. You can develop acute renal failure. If you're dehydrated and you take a big dose of ibuprofen, you can precipitate kidney injury in that dehydrated state.
You guys do. You guys, so many of us do use these.
I use it. I mean, everybody uses it.
Yeah, no, I
at
use
some
it.
point, but-
I'll put a plug in for ibuprofen. I love it.
So that's one thing. The bigger issue is the chronic, repetitive use of anti-inflammatory drugs will lead to what's called interstitial fibrosis or chronic interstitial nephritis. So your kidney is a very hostile place. It's not a...
I thought you said it was nice.
I never said that.
No, it's hostile.
So I don't have anything to draw on, but so your kidney is divided into basically two sections. The outer shell of the kidney is where all the little filters are. That's called the cortex. The inner area of the kidney is the medulla, and that's where all the tubes and the blood vessels are. That inner area of the kidney has very low oxygen levels because blood flows through in a double circuit and gets used up in the filters. So to maintain good blood flow through your kidney makes certain small hormones called prostaglandins. Prostaglandins keep your arteries open in your kidneys, keep the blood flowing. So when you're dehydrated, your kidney prostaglandins go up and good blood flow is maintained. Well, you have a lot of prostaglandins in your body. Some of them cause pain and inflammation. So when your muscles are sore from playing 36 holes of golf when you should have stopped at 18, your prostaglandins are being revved up and causing pain. You take your ibuprofen, it blocks those bad prostaglandins, but it also blocks the good prostaglandins. So the chronic repetitive blockage of that protective system in your kidney will lead to damage within this inner part of the kidney. And I see several young 20s, 30-year-old former professional athletes who have significant chronic kidney disease from non-steroidal use. A lot of baseball players, pitchers, they live on non-steroidals when they're 18 to 25 and they're pitching and they have chronic sore shoulders and they're trying to break into professional baseball. They're taking...
Now, are they taking doses beyond what we would take? I mean, like maybe
they're taking doses you would prescribe, 600 to 800 of ibuprofen.
So just standard stuff, high dose of
a couple of times a day.
Okay.
But it's that chronic, repetitive use. They tend to get dehydrated because they're playing competitive sports, and then they take all this anti-inflammatory.
So anti-inflammatories are definitely on the list of things one needs to be cautious about. That doesn't mean you don't use them. I mean, it's a trade-off. If you use them, you have to be getting a benefit.
Yeah.
And if you're using them regularly, you need to check your blood tests
That's right.
for your kidney function to monitor this situation.
Yeah.
Let's talk about another thing that I think of, on my top 3 list. Number 2 on my list would be iatrogenic, as in the fancy word for doctors did that, dye. Would that be number 2 on your list or no? That's number 2 on mine to talk to patients about. What would be number 2?
It wouldn't be.
Okay, what's number 2 then? And we'll come back to dye.
Hydration.
Okay, so dehydration.
Simple stuff.
Not hydrating.
Avoiding dehydration and staying well hydrated and not with coffee or lattes, with water. Water is the best fluid you can drink. I mean, it's what you're made of, so you might as well drink it. The next series is probably other medical conditions that need to be properly attended to. Your blood pressure needs to be well controlled. If you're diabetic, you need an A1C of 7 or lower. If you have heart disease, cardiovascular disease is probably a very big risk factor for renal disease. There's actually a new society that was formed by some of your physicians in your neighborhood, Dr. Vijay, myself, Dr. Singh, called the Cardio-Renal Society of America, because we recognize the interrelationship of cardiac disease, renal function, and diabetes is part of that mix too. So remember, your filter, your kidney, runs off what your heart's doing.
And what percentage of your blood is, the kidney uses 20%?
About 20-25% of
20%.
blood flow every time your heart beats goes to your kidney. So if your ejection fraction is reduced by 20%, blood flow to your kidney is reduced by 20%. Similar to how the anti-inflammatories can harm your kidney, chronic low blood flow from chronic heart disease, especially decreased heart function, can lead to decrease in kidney function over time.
Although that's not a direct thing. I mean, the kidney opens up its vessels to try and grab more of that.
Correct.
flow.
It tries to compensate, and it
So it
does
has
quite
methods.
well. But there comes points where
It cannot do that, or
there
can't
is
quite
this
do it.
decompensation, and each organ makes the other one worse, and it's hard to get people back from that. Dye is on the list,
Okay, so that's number 2 on your list, which is medical conditions.
which is
that need
comorbid
proper-
conditions that
okay.
need to be properly
Okay,
managed.
and dye is on the list?
Dye is on the list,
Okay,
but
it's not high on your
it
list.
really depends on who you are.
Okay.
The way dye hurts your kidneys, it's not directly kidney toxic. It's vasoconstricting. So
Which means?
it constricts the blood flow. You're going to see a recurring theme of blood flow, blood flow, blood flow, because that's all your kidney is a ball of blood vessels. It's all about blood flow. It causes spasming of the arteries in the kidney and decreases blood flow to the kidney. Certain people are at higher risk for contrast-induced nephropathy or kidney injury. If you're diabetic with diabetic kidney disease, protein in the urine, you're diabetic with protein in the urine, you're at higher risk of contrast-induced kidney injury. If your creatinine is above 2, our radiologists actually use 1.5 as their cutoff, where they won't give you contrast unless they call your nephrologist and the nephrologist says okay. But 2 is the big risk factor. And the third is how much dye you get. If you get over 100 cc's of dye, your risk of kidney injury...
Which is not that much, might I say. Well, 100 cc's is like 3 ounces?
Depends on what you're
A little
getting
over 3
done.
ounces.
So it's interesting. To do just a diagnostic heart angiogram, our cardiologist could do with 40, 50 cc's of dye. As soon as they go to put a stent in you, that goes up to 200 to 300. Because to put a stent requires multiple pictures. They got to take an opening picture. They got to put the stent in. They got to check position. They got to do a closing angiogram. They use several hundred cc's of dye to do a stent.
So they're using about a can of Coke worth of dye to do
can.
that particular procedure. But usually they're using about just a few ounces off the bottom of the can.
So a CT angiogram will use up to 150 cc's of dye to do a CT angiogram.
Okay, so that's 5 ounces.
So sometimes if you need an angiogram of your legs or something, it's sometimes better to do a regular angiogram by the radiologist where they'll use 20 or 30 cc's of dye than doing a CT angiogram. It's a trade-off. But if your kidney function is normal, the risk is minimal.
Okay.
And I'm sure if we looked at people with normal kidney function who get angiograms, if we do their creatinines 2 days later, we'll see a certain number that the creatinine will be a little higher. But within 72 hours, it starts to come back to normal. Most of the change of GFR, change of creatinine post-dye goes away, no matter who you are.
Okay, then what goes on your what else is on your list besides that? I have one more thing that I put on my list only because I thought it was worth educating people about, and that was colonoscopy preps, specifically the
Phosphorus preps,
phosphorus
which no one
preps.
is going to give that to you anymore.
So we're not seeing those anymore.
So
Those
there
are
was-
absolutely not going to be given. Nobody's
Absolutely
giving
not. No GI guy is going to give you phosphate prep for colonoscopy ever because of this risk. You absorb all the phosphorus through your colon, and you get these calcium phosphorus when it binds together makes bone. I mean, it's solid. That's what your bone is. It's calcium phosphorus. So you don't want that forming in the middle of your kidney. So this huge load of phosphorus, your kidney's trying to get rid of.
So that was the former type.
That was
there
the
are no,
former
So there are
type.
no current colonoscopy preps that are
So
concerned
I think
to your
everybody
kidneys.
does now the old school go lightly, the jug, or these new preps with Ducalax and Miralax and some other combinations.
So none of the sodium picolinate and these other ones don't have any
No.
nephrotoxicity?
No,
I want to know this because this
If
is...
you have heart disease or kidney disease and your GI guy gives you the big jug of Go Lightly, don't worry about it because it's all going right through you. You don't really absorb any of that. It all just flushes right through.
Okay. All right. So now where were we with that? We were talking about ways to keep our kidneys healthy. So you're talking about the different things that we need to watch for.
Yeah, I mean, your kidneys are usually secondarily affected by other problems, and it's really taking care of those other problems as best you can. You know,
Now we didn't get to talk about salt. Can we talk a little bit about salt as being something? Is that good? Is it bad? What is your? I mean, are there two camps on this comment of salt? There was a big article. I think I mentioned to you that I saw. It was a headline in the English newspapers that salt was causing so much illness in England, and they were going to take it to task. And I don't know if this is true or not. I just saw it as a headline.
well, I mean, it is true to some degree, but it depends on who you are. So salt causes fluid retention. In a normal physiologic body, if you take a lot of salt, you're going to pee out a lot of salt. Your body's going to adapt to your salt load. Your kidneys will adapt to your salt load. So if you look at urine, salt, sodium excretion on someone, when you put them on a high salt diet, after about 48 hours, their urine sodium goes up dramatically because your body's going to hold on to what it needs and dump out what it doesn't need. Now, if you have a chronic disease that stimulates salt retention, you can't get away with that. So if you have chronic heart disease, decreased cardiac function, cardiomyopathy, if you have chronic kidney disease or chronic liver disease, those three organs, when they don't function properly, stimulate the production of certain hormones within your system, which lead to the production of something called aldosterone. Aldosterone is a hormone from your adrenal glands. The purpose of aldosterone is to retain salt and water and raise your blood pressure. When you have these organs that don't function, you have an inappropriately elevated production of this hormone, so you become very salt sensitive. So if you take salt and you have one of these disorders, you're going to retain water. In the case of kidney disease or liver disease, you're going to swell. In the case of heart disease, you're going to go into congestive heart failure. So
for a 70-year-old who's basically I'm a healthy 70-year-old, yeah, I take a blood pressure pill. Should I be particularly concerned about my salt or not particularly concerned?
Well,
just curious as a recommendation.
it depends on who you are.
No, come on. I want to answer.
So, calm down. So maybe some of the issue in England is because you have a genetically and ethnically less diverse population. Although England's a pretty international country, but the main population of England are English. Yeah. The main population of the United States is from everywhere else because we're so big and so ethnically diverse. But if you're hypertensive, it's a flip of a coin whether you're salt sensitive or not.
It's 50-50?
It's about 50-50. So there are two groups of hypertensives, salt sensitive and salt independent. And the difference has to do with what drives your hypertension.
And how can somebody know this?
Well, we can do, and I sometimes do profiling in the office, renin, aldosterone profiling. So if you're salt sensitive on a high salt diet, your renin and aldosterone, those are the hormones that lead to salt retention, are very low. Right? You hold on to salt, you shut off those systems, and that's who you are. If you're salt independent, you tend to be high renin. These are people with kidney disease. African Americans tend to be high renin, salt independent. Whites tend to be more salt sensitive. So you can do a profile. I'll tell you, I've done this a long time, that I don't spend the money.
Yeah, nobody really does.
I can usually tell if someone's salt sensitive and someone who isn't, based on some is ethnicity and background. Some is, if you have a little peripheral edema and you're hypertensive, you're probably salt sensitive. And salt sensitive people do well with diuretics. A little hydrochlorothiazide make a tremendous difference in someone's blood pressure if you're salt sensitive. If you give it to someone who's salt independent, it won't do anything for their blood pressure. They need ACE inhibitors and ARBs and these other drugs. Salt-sensitive people, everybody does well with calcium blockers or beta blockers. They're kind of junkyard antihypertensives that work for everybody. But whether you need diuretic or ACE inhibitor is the decision point.
I got a question. So we're talking about salt, whether salt is good or bad, and
Yeah.
it's particular to the person. What other things in the diet are concerned? Is protein a concern in a general sense for us, or not particularly?
Not in a general sense. It's only a concern if you have decreased kidney function. Again, remember, protein you eat makes urea, but your kidney does need to get rid of it. So one of the things we do with chronic kidney disease patients, we have dietitians in our office, and they counsel our patients on decreased protein intake, and they will create a protein intake for every patient individually, depending on their stage of kidney function and nutritional status. It has an impact in decreasing progression of kidney disease. Is it a huge impact? No. Your blood pressure and diabetes and heart status is more important in slowing progression of kidney disease, but it does have a measurable effect. And it's interesting, patients who come to us who have late stage 3 or early stage 4 chronic kidney disease and truly follow the diet, you see their GFRs stabilize. We see that they come to us and we see this trend of decreasing GFR. They get dietary intervention and it just kind of plateaus. Some of them actually get a little bit better by just modifying their diet, getting rid of the salt, getting rid of the protein.
So these are people who have issue. But
These
what
are
about
people who have issues.
Let's say a 65-year-old guy who wants to go on a Paleolithic diet where they're eating fat and protein and so forth. Are you worried about their kidney? Let's say they have hypertension, they're on a blood pressure pill. You're not going to worry about that.
I'm not going to worry about that.
Okay.
I
So
think the benefits of the weight loss far outweigh any small risk of protein loading.
Okay. I want to touch on one other sort of general topic that I think is sort of one that comes up all the time in the office, and it has a lot of different ramifications. And then we'll take some questions from the audience. The question is about edema, swelling. Now, patients find edema even the least bit. I mean, and I don't want to sound sexist here, but women more than men, but men still too. Edema is a scourge. And when they come into the doctor, don't get me wrong, but when I see a patient with some swelling, a little bit, I'm like, my first thought is, can you live with this? I mean, do we really have to deal with this? Because I'm thinking, let's just let it be and let the body be.
Yeah.
But what do you have to say about edema too, as we think about it? Should we, when we see it, obviously it could be a sign of disease, but let's not talk about somebody who has some underlying serious health condition. Let's just talk about, a person who has swelling for whatever reason, they've retained a little salt and water, multiple factors potentially. What do you say to that person? Don't worry. How do you reassure? What do you think of it? Or do you think of it? No, big deal.
Well, the first thing I do is ask them if they're on Norvasc.
Okay. So it's a medicine.
So medicines.
Number one.
Certain medicines
Yeah,
cause
amlodipine.
swelling. Amlodipine, Norvasc,
Yeah, notorious.
15% of patients on it.
Yeah.
I think it might actually be higher than that.
Yeah,
but
I
the
would
studies
agree.
say 15
Yeah.
will develop swelling. And it's not salt retention. It's vasodilatory, and it won't go away with diuretic. You just got to stop the medicine and put them on something else.
It's
Norvasc.
amlodipine. Amlodipine. Very common medicine.
Great
Used a
blood
lot.
pressure medicine
Great pill.
if it doesn't cause swelling. If it causes swelling, you got to use something else. And that, well, every drug in that class does the same thing. So if you swell with Norvasc, you're going to swell with Procardia, you're going to swell with Sular. They're all the same type of calcium blocker. There's another group of calcium blockers that might be okay. You may not swell with them. Or there are dozens of other.
Yeah, and you have to
blood
switch to
pressure
an
medicines.
alternative agent.
You go to
your
a
whole
different
group.
class of drug is
Yeah.
usually the best way to do it.
Or you live with it. I remember I said live with it.
So
Deal.
I'll take you back 20 minutes ago. So if you take a high salt diet, you're going to reach this steady state where you can excrete more salt. If you don't have heart disease, and you don't have kidney disease, and you don't have liver disease, and there's no protein in your urine, and you're having some swelling, stop eating salt. When you drop your salt intake, your kidney will get rid of all that extra salt and water, and you'll come to a new balance point. So no salt. If you're swelling and you're otherwise healthy, you're just eating too much salt.
But I got a comment for you, Savas, because what happens is typically somebody says to me, well, there's not a person here who probably uses a salt shaker anymore. But that's now about 8 or 10% of the salt in your diet max out of the salt shaker. But everybody's like, I never use a salt shaker, doc. No salt in my diet. It's like, wrong. We all got salt hidden in things. I mean, anything in a package obviously is going to have salt in it.
Well, any restaurant you
Anything
go
prepared.
to, if the food tastes good, there's too much salt in it.
Yeah.
I mean, that's right. I mean, that's the purpose of salt. Salt stimulates your taste buds so that you can taste everything else. That's why in Chinese food they use monosodium glutamate. It's not for preservative reasons. It's because the sodium makes the flavors of the food pop. And that's why we're addicted to it as a society, because it makes everything taste good. But you got to fight the urge.
So what do you tell people? I mean, do you have a simple, I mean, any simple guides? I'd really like to know, because I'm going to learn something here, about a simple way to tell, because people say, well, I don't use a salt shaker. I'm like, well, that'll solve it. Next. It's like, no, that's not going to solve anything. They're going to have edema still. They're still going to swell. So what are they going to cut out? What are the biggies?
Well,
I mean, what do you point to? Do you have like 2 or 3? You say, cut out this, this, and this,
well,
and you'll make a big difference.
you got to
Or
get
there
rid
is
of
nothing.
any type of processed food.
Okay, so anything in a box or
Anything
out
in a
of
box, anything in a
package?
can, or
cut
anything
that
from the
back a bit.
deli counter.
Okay.
You know, you can get some low
salt
salt
turkey,
cold cuts, but you know what? You like turkey sandwiches? Buy a turkey breast and cook it. And you'll have turkey for the next week. And you know, if you really want to get rid of salt, you got to cook for yourself. You got to control what goes in your mouth. It's very difficult to go to any food establishment unless you're ordering raw food, unless you're ordering salads, and say don't put any dressing on it, just put little vegetables in a bowl.
What's
to
the
get
point of
away
going
from
out
salt.
then?
Well, I'm not saying you can. It's necessarily
I know.
feasible, but I mean that's how you have to do it. I mean, if you really want to cut back your salt, no fast food, nothing that's been processed or preserved. If you go to a restaurant, you want to go to restaurants that cook to order, that cook fresh food to order. You know, Red Lobster cooks to order, but all their shrimp is preserved in sodium phosphate. I mean, it's not really all that good for you. I had a friend,
There goes Red
who works for the largest shrimp distributor in the world. I met him at a leadership conference at Harvard a couple years ago, and he made me swear off of Red Lobster. So,
Oh, no.
he doesn't send me any shrimp though. I don't know.
Now, I've got one other topic, and then we're going to get to questions. The quick topic is single kidney patient, or becoming a single kidney person, deciding to donate a kidney.
Yeah.
If anybody has that kind of guts and commitment to humanity, I personally don't currently have that. I might give something else, but not that. Right now, at least not to a stranger. But there are better people than I, and I give them credit. Tell us about just very quickly, just living with one kidney. You know, should one live in fear? I mean, you know, people.
Well, you shouldn't. I mean, there are a certain percentage of the population born with one kidney. My brother-in-law has one kidney. We got a couple of people in the family born with one kidney that was found incidentally on some imaging. And we have a large population of patients who've had renal cancer, and the treatment of that is you take your kidney out. We do other things now with cryoablations and things like that. So there are lots of people walking around with single kidney, and then there's all our donors, all our living donors. I mean, more than 50% of the transplant done through the Mayo Clinic system are living donors when you look at the 3 sites around the country. And there is no significant increase in renal disease in that population in multiple studies over multiple years. The only thing you're at increased risk for is trauma, is a traumatic injury to that kidney. And renal trauma, even in big motor vehicle accidents, is pretty rare. You can get contusions, but it's very, very unusual to have a kidney removed or partially removed because of traumatic injury. And it's not enough to not donate a kidney. I got to be completely straight. There was one recent study that did show an increased risk of renal decreased GFR, loss of kidney function in renal donors, just recently published. But it really flies in the face of dozens and dozens of prior longer studies that did not show any risk. The reality is, if you develop a medical disease that's going to cause kidney disease, whether you have 1 or 2, the damage to those organs is equal. It's not like your diabetes kills one kidney and leaves the other one alone. You know, it's going to hurt both of them equally, and the rate of loss is the same. So there's really not a big increase.
So you don't see
risk.
any legitimate arguments against it, and you would feel comfortable yourself doing it if
Yes.
you. Yeah. I mean, okay. Just curious. All right. Very good. Well, a round of applause for Dr. Petrides. Thank you very much, Savas. And then we're going to have questions. If you want to do your bullet points, then we can have questions. That's fine.